I'm a medical officer at the Aging and Health Unit, lead on long-term care at the WHO headquarters in Geneva, and I will be moderating today's session. Before we start, I would like to make a note that all attendees are muted by default. If you have a question that you would like to ask any of the panelists or panel members, please submit it through the Q&A feature. Attendees can vote up questions they agree with at the end of the presentations. I will select questions from the Q&A feature to direct to the panelists. The third in its series, today's webinar is a deep dive into long-term care facilities and long-term care services in hospitals during a pandemic and technical guidance on a safe long-term care facility and hospital environment. WHO defines nursing homes, skilled nursing facilities, assisted living facilities, residential facilities collectively as long-term care facilities that provide a variety of long-term care services, including medical and assistive care, to people who are unable to live independently in the community. As we all know, long-term care facilities have been the epicenter of outbreaks throughout the COVID-19 pandemic. Although countries have made efforts to manage the outbreaks seen in long-term care facilities, the wide-reaching health and socioeconomic impacts of COVID-19 pandemic are far from over. Thus, there is a need to continue and further strengthen our bonds, the sharing of our experiences and lessons learned regarding living with the pandemic. So today we have here distinguished speakers to share excellent experiences in long-term care facilities and hospitals providing long-term care services. They're Dr. Hanadi Al-Hamad from Qatar, Dr. Felipe Cruz Vega from Mexico, Dr. Hong-Soo Kim from Republic of Korea, Dr. Joanne Rice Snyder from the USA, and Dr. Hugh Masters from Scotland. We will move on with our third webinar in the COVID-19 Safe Hospital webinar series, cognizant that hospitals and other healthcare facilities, such as long-term care facilities, play a critical role in controlling the pandemic by slowing down COVID-19 transmission and reducing deaths associated with it. So for our first opening remarks, I am honored to invite Dr. Edward Kelly, a favorite of mine as well, former director of Integrated Health Services Department and currently senior advisor for WHO on COVID-19 and health systems, for his opening remark. Dr. Kelly, you have the floor.
Thank you so much, Zia, for those kind words. And it's just been a pleasure working with you and the whole team on these webinars, but also on the work together. Most of you will know that long-term care is one of these areas that spans many different parts of specialist areas, and Zia has been one of the key people to bring all that together. Not an easy task, but it just falls to me to say good morning, good afternoon, and good evening to all of you, and greetings to our distinguished speakers and to all the participants from around the world. I'm really very pleased to welcome you to the third webinar of the COVID-19 Safe Hospital webinar series. I thank our partners, the United Nations Office for Disaster Risk Reduction, and the International Hospital Federation, a group that I've worked with personally for many years, and likewise WHO colleagues for organizing this webinar series to further support hospitals and other care facilities in scaling up their capacities to manage the risks of COVID-19 by sharing the good practices, their experiences, and the tools and guidelines used. 2020 has been an extremely challenging year for the world, and 2021 has started in much the same way as 2020 finished, challenging for the World Health Organization itself, and especially for older people and vulnerable people whom we need to serve. From available data that WHO's analyzed, 1 in 4 individuals infected in long-term care facilities died from COVID-19. Most estimates put the case fatality ratio greater than 10% in people over 65 years of age, which is 5 times higher than the current estimate of more than 2% case fatality rate globally. In countries with higher proportion of older populations, primarily high-income countries, have fared worse, unfortunately, as the risk of death associated with COVID-19 rises steeply with age and the comorbidity associated with it. This pandemic has taught us lessons about caring for each other, but more so about caring for the most vulnerable in our societies, including older people. We know that COVID-19 has changed our lives, but to a larger extent, older people's daily routines, the care and support they receive, their ability to stay socially connected, and how they are perceived have changed dramatically. It's therefore important to create opportunities to foster healthy aging during the pandemic. One of these opportunities is protecting the essential infrastructure that saves lives, safe long-term care facilities, and safe hospitals which offer long-term care services. Residents of long-term care facilities often face high risk low preventive measures, and inadequate resources to recover from COVID-19, as well as reduced access to essential health services in a context where health systems are experiencing constraints during the COVID-19 surge, where there is community transmission especially. So far, COVID-19 has disproportionately affected long-term care facilities. In a 2020 study by the United Kingdom Office for National Statistics of deaths by occupation, for example, we found that the social care workforce had a significantly higher death rate associated with COVID-19. Concerted action, therefore, is needed to mitigate the impact across all aspects of long-term care, including home and community-based care, given that most users and providers of care are those who are vulnerable to severe COVID. The actions for long-term care services will be one of the fundamental and essential steps in mitigating the COVID-19 pandemic in many countries. Only by addressing long-term care facilities and services will countries and communities be able to truly leave no one behind. And this will be highlighted as well during the forthcoming World Health Day on promoting health equity. The pandemic has brought to the fore the need to address long-standing problems in long-term care services and systems. And this includes underfunding, lack of accountability, the fragmentation of services, something that we saw so apparent in the early parts of this pandemic. And of course, an undervalued workforce that itself can also come from many parts of the health infrastructure. Certainly, there are ways to transform to a direction where long-term care services are readily integrated and provided as part of the continuum of care that includes health promotion, prevention, treatment, rehabilitation, and palliation. The COVID-19 pandemic, like any emergency or disaster, has been a devastating reminder of the interdependency and linkages between our sectors and the need to engage all sectors under the highest political leadership for sustainable efforts toward community resilience. And one more word, together. Such work cannot be done in silos. Sustainable capacity to respond to future emergencies will need, first of all, coordinated leadership from global to regional to country levels. UNDRR and other UN bodies and respective national level authorities and partners are key to build public health system capacity, security, and promote health as key to national development. WHO's Health Emergency and Disaster Risk Management Framework and recently published operational guidance on the whole of society approach to health, to manage health risks and reduce socioeconomic impacts of emergencies and disasters. All of that highlights the concept of risk-informed actions and a strategy with criteria on how a whole of government approach will implement decisions on the proper management of long-term care facilities and other settings where older people must be prioritized with care, to be vaccinated against COVID-19 in order to lower the risk of transmission, incidents, and deaths. The WHO Rapid Hospital Readiness Checklist, which is part of an integrated WHO data tools for COVID-19, can be used in assessing the preparedness of long-term care facilities and implement priority actions to help those facilities be fully functional as possible. And I'll close with just noting that today's webinar will focus on all of these challenges, a lot of them, with a set of marvelous speakers. And that in view of that, we've really looked for a panel that could look across the different parts of the world and also be able to share experience from actual long-term care facility management in the context of the pandemic. Carefully documenting the key messages conveyed in this webinar series to transform it into actionable recommendations is one of our priorities. And we look forward to working together with you on how all of the strategies, guidance and practices can be captured and can be integrated into longer-term lessons for long-term care facilities to make them safe, functional, and resilient. I wish you all a productive, safe hospital webinar. Thank you very much, and back to you, Ziha.
Thank you so much, Dr. Kelly. Thank you, Ed. Now I am pleased to invite Mr. Sanjaya Bhatia, Head of the Office of United Nations Office for Disaster Risk Reduction, Office for Northeast Asia and Global Education and Training Institute for Disaster Risk Reduction in Incheon, Republic of Korea, for his opening remarks. Mr. Bhatia, please take the floor.
Thank you, Dr. Zian, and again, welcome to all the participants. Let me at the outset thank the World Health Organization and the International Hospital Federation for collaborating on this series and seeing the participants, the numbers of participants in today and in the past ones. I see that this is quite very useful, very fruitful, and also quite popular. So congratulations to the team working on this series. I just wanted to bring to all our attention that the COVID-19 situation has revealed to us significant failings in disaster risk reduction, which is well promoted by the UN Office for Disaster Risk Reduction, which I represent, but also by all the actions taken by World Health Organization and the International Hospital Federation. Some of you will remember the Sendai framework for disaster risk reduction, which was adopted in 2015. I wonder how many remember that biological hazards were for the first time added to an agreement of this kind in Sendai. And this was because the UN member states insisted, based on the recent experiences that they had responding to outbreaks of Ebola, SARS, MERS, and H1N1. UN member states since then have had more than 5 years now to put in place national, local disaster risk reduction strategies, which could cover the full range of hazards and events, including biological hazards and pandemics. Unfortunately, very few have made that link well. And that's why it is important to continue to have these kind of webinar series and communication modules and training modules so that this message goes out clearer and also that the tools become available. So when we talk about disaster risk reduction, it requires a clear vision, it requires some planning, it requires guidance and coordination within and across sectors, just like the earlier speaker also mentioned, breaking down the silos and ensuring that all sectors are fully engaged along with the communities and the civil society. One way of measuring this progress is against the implementation of the key targets of the Sendai framework, including reducing loss of life, reducing the number of people affected, and reducing economic losses. But COVID-19 has been an enormous setback for all of these efforts and also has serious implications for the efforts to achieve the Sustainable Development Goals. The Sendai framework included a target to have the national and local strategies. Over the years, we have seen slightly over 81 strategies have been developed so far. But very few have the adequate inclusion of biological hazards and or pandemic preparedness. And this is a cause for concern, and again highlights the need for continuing this process of communication and outreach, but also to ensure that these links are made more clearly. We all know that the impact of COVID-19 has been immense. The World Bank estimates that more than 100 million people will be moving into poverty. So this is the new poor, which will be coming in, which will be in the world. And out of this new poor, of course, the most vulnerable impacted by COVID have been those who live in dense, overcrowded, informal settlements with poor access to basic services. Most of these vulnerable and the new poor are in the cities, in the urban areas. And so it is becoming more and more challenging to have safer, resilient, and sustainable cities. The importance of looking at multi-sectoral coordination, the necessity to reduce risks at their root causes, so addressing the underlying causes, and the urgency for a multi-hazard approach which integrates health emergencies and health biological hazards along with other hazards is more than ever evident at this point of time. And we hope that the lesson is learned, and going forward, this will happen more. but it is taking a long time. Considering this, UNDRR also tried to create an initiative to help to make cities safer, resilient, and more sustainable. And this was the Making Cities Resilient campaign, which ran from 2010 to 2020, December, with more than 4,300 cities and local governments joining. Amongst these cities, there was a clear commitment to adopt a risk reduction approach, a multi-sectoral approach, a multi-hazard approach, and which to some extent included also the addressing the health sector. Now with the new year, we have launched another initiative called the MCR 2030. Which of course goes on till for the next 10 years. It builds on the experience of the last decade and tries to bring all these institutions which can help cities become more resilient and safe, including WHO and other partners in the health sector. What the MCR 2030 does is provide a 3-stage resilience roadmap for cities. First, to enhance knowledge on risk and resilience. Second, to put in place disaster risk reduction and resilience strategies. And finally, to support them in the implementation and actions that they take to strengthen resilience. Cities and partners that sign up will have access to tools and services provided by a wide range of organizations, including those from the health sector, and will receive support to progress along the resilience roadmap. So all of these tools are being provided through an online dashboard, and we see potential for the tools and the guidance on safe hospitals to be part of the offer to cities. So I will end my remarks with a request and a call for members from the health sector, including all partners of the World Health Organization and the International Hospital Federation, to join the MCR 2030 so that they can provide their services, the expertise, the knowledge products, the tools that cities need to integrate the health sector in all their planning for disaster risk reduction, and to support the process as service providers. With this, I would like to end my remarks. I want to congratulate the organizers, our collaborators, WHO and International Hospitals Federation, again, the teams behind this, and I hope you enjoy and you find this today's webinar very informative and fruitful. Thank you.
Thank you very much, Mr. Bhatia, and thank you both for the opening remarks for setting the tone of our webinar. Now let's welcome our 4 panel speakers for this 3rd webinar. I would like to now start the first panel discussion, and the first presentation will be on the experience from Qatar. I would like to invite Dr. Hanadi Khamis Al-Hamad, Medical Director, Rumaila Hospital and the Qatar Rehabilitation Institute, also the National Lead on Healthy Aging for Qatar. Dr. Hanadi, you have the floor for 8 minutes. Thank you very much.
Good afternoon all, and thank you for the invitation. Thank you for giving me this opportunity to share Qatar experience. I want to start that I have no disclosure or conflict of interest to disclose, and I will start my presentation same as Dr. Edwards nicely highlights regarding COVID and long-term facility. Massive outbreak being reported across the globe and over all the world. There was effect, of course, in our elderly and long-term patient, and in many countries it was really death happened, during the pandemic. Here in Qatar, how can I move the slide? Sorry. Yes, the next one. In Qatar, the first case reported, it was on 29th of February 2020. And Department of Geriatric and Long-Term in our corporation, we call it Hamad Medical Corporation, had a quick and implement response of this pandemic, and we respond, especially we have in our geriatric department, vulnerable group, which elderly and long-term patient. This map of the state of Qatar, and I want to share with you when we have the pandemic, the first point for me is how to reassure our elderly in community. So most of the services, they stop their outpatient clinic and rehabilitation services. So I deploy those manpower to start services. I call it telephone reassurance call. We start to call elderly, I start with 65 years and above, and reassure them about pandemic, what is COVID, and how it's spread, importance of hand hygiene, keep themselves safety and stay at home. And we start to call each one of them because at the beginning, it was not clear for them. We establish also in addition, SMS messages went to all elderly in the country. And in this message, it was weekly message, but alternate. One message about pandemic, other message important to take their medication, other message to stay safe during this pandemic, dietitian control, try to move and mobilize even if you are isolated at home. So it was different message across 2020 till alhamdulillah, that time we decreased the number of cases. In addition, we came all the department, we came in the press release, social media, we start to aware and educate the community, and we have different video, even we draft video about rehabilitation elderly, how to prevent to fall, how to mobilize in this difficult time, different messages about pandemic. I have 5 facilities here at Qatar, and some of the facility connected by each other through bridge, and some allocated in different area of the state of Qatar. I have a good number of population inpatient, almost reach 600 inpatient. So my scope for long-term facility, it's different than international nursing home. Due to culture and widening scope of patient to support patient acute bed, we have physician-led and multidisciplinary, of course, approach in our long-term facility. In addition, we have on-call system, so physician physically, they are in the facility, and our long-term facility planetary certified and GCI also accredited. So what we did during pandemic, I will go not to the other slide. Yes, the other one. So during the other next one. So during pandemic, I brutalized with my team our, this is photo for our facility, how they connected through bridge, and some facility, as I mentioned, they are far away. We brutalize our steps. One of steps, I have to mention it, but it was painful really that time. I have temporary to stop the visitor coming to long-term facility, except patient who's end of life or dying patient. And I replaced the visit by something I call it video call. So we are doing a weekly video call, and so for some of the family who's anxious and really conscious patient, they want to communicate, we did video call through our case manager and multidisciplinary team. The aim of the video call to reassure the patient, connect them with their family, discuss any new things happen to the patient. Of course, implement and monitor appropriate use of PPE. It was one of important point, including emphasize on hand hygiene. We canceled the important, some of the meeting, and we left it for very, very important meeting and activity. And we stopped gathering of elderly during this time and long-term patients, unfortunately. And we try for rehabilitation part to take them in a smaller, very small group. I have strategy monthly, unfortunately, to screen staff, but I have to protect my inpatient elderly and long-term patient. So screening of the staff, and I screen any patient admitted to a facility. Of course, management and surveillance of the exposed staff, it was burden and panic. You find one staff positive in this, and they have to do tracer and find this staff communicate with home. And one of the measure I did also, the lounge, the area they are eating, I separate them and I allow them to eat in separate and not more than 3 at a time. Of course, we follow WHO recommendation, and I have good chance, and thanks WHO. I reviewed that time the first draft of prevention and control standard in the long term, which is, if you didn't read it, I might advise go and read it. Very excellent material and draft. And it helped me really to strategize and arrange my thinking. As I mentioned, we tracing and brutalize spread of infection through swabbing, relocation of resource as demanded, because many of our nursing deployed to COVID positive facility. Education and monitor of our staff, it was important. Ensuring food safety, so I have to stop food coming from outside for patient and for staff. And it was one of my observation, some of the staff, especially the housekeeping and nurse assisting, they accommodate in a small accommodation. So what I did, I cohort them and listen to our HR, and thanks our HR, they provide them with accommodation, a temporary accommodation and transportation. Of course, hand hygiene, terminal cleaning, it was one of the measures. The next slide I want to share with you, I have to close many entry here. As you see, I keep all the facility, and each facility one point of entry with a triage, a questionnaire and triage for even the staff with checking their temperature before they are coming. And this is part of mass screening for staff. I did it monthly till the pandemic reduced the cases in state of Qatar. And here I'm coming regular in the press release, educating the community, TV, sending messages. This initiative from my nurses, as you know, nurses always, they are creative. They came with, maybe it's not readable, stay home, you stay home safe, we stay here for you. So all the nurses, they start to share their colleague, and I copy them. I follow what my nurses, they came with, and we spread it across all state of Qatar through messages, WhatsApp, social media, whatever. The other slide I want to share with you, patients receive what we did also during pandemic, or from where I received the patient. My patient, they are coming from acute setting. They are coming from community. Some of the family, they call us because they became COVID positive and this elderly not affected. I have to take them as respite. And here, this may be, you know, I don't know if other countries they have it. Some of elderly, they are under treatment abroad in UK or USA or Germany. So during pandemic, they have to come back to their country. So I open quarantine unit. So those elderly not fit to go in hotel, or because they are disabled, they need care. So I opened quarantine unit direct pathway from airport to this unit, and we swab them in the airport. I allow one caregiver to be with them, and we quarantine them. At the beginning, it was 14 days, then it came 7 days. And after I swabbed, came negative, I try to do my best rehabilitation them and engage them in some of the activity in their quarantine. Pandemic, this last slide for me, pandemic is negative, but there is positive for me and for my department. It was one of my dreams to have national headline for elderly. And you know, during the pandemic, anything you will ask, they will support you. So I'm supported national geriatric headline, and it's still functioning from last March till now. And believe me, very excellent feedback from community. Easy access for my elderly, emergency very busy, and they're scared to go from cross infection and they get infection. So I open something as subacute, urgent unit. I call it Geriatric Daycare unit. We open every even weekend till 10 p.m. We opened acute geriatric assessment unit instead of the elderly admitted acute setting. I moved the scope from tertiary hospital and patient need admission. I admit them in part of my long-term facility. It's hospital setting. This why it helped me. Telephone reassurance, I share with you. National helpline for Alzheimer patient. Telepharmacy, disposing medication to elderly at home, and reconciliation before we dispose the medication. I open observation unit for elderly and weaning units, step down from ICU, and telemedicine instead of face-to-face, you know, as alternate virtual clinic, not to stop the service for elderly. So thank you. This part of my infographic. Thank you to listen to me. This is all what I mentioned, and I wish all to stay safe and healthy.
Thank you very much, Dr. Hanadi. An excellent overview of what you are doing and excellent good practices that should be shared. The use of telephone reassurances, SMS campaigns to reduce information barriers to ensure continuity of comprehensive geriatric care. So thank you for those examples from Qatar. Now I would like to give the floor to Dr. Felipe Cruz Vega, head of the Special Health Projects Division in the National Medical Direction, Mexican Institute of Social Security, Mexico. Dr. Vega, you have the floor for 8 minutes, please. Thank you.
Gracias a la Organización Mundial de la Salud y a la Federación Internacional de Hospitales por esta invitación. En la siguiente diapositiva estoy ilustrando, las diapositivas las manejo de aquí, ¿nos ayudan? A ver, siguiente diapositiva, perfecto. Les voy a compartir las acciones estratégicas tomadas en el Instituto Mexicano de Seguro Social durante la pandemia y el impacto del Hospital Seguro en la respuesta con niveles altos de seguridad ante la pandemia. En la siguiente diapositiva, por favor, quisiéramos recordar, next slide please, quisiéramos recordar la definición que se acuñó desde el 2005 en Covert sobre hospital seguro. Accesible quiere decir que todo el mundo puede llegar a él en el momento de la emergencia o desastre, incluidas las personas con discapacidad. A su máxima capacidad instalada. Esto quiere decir no como diario, que en ocasiones estamos saturados, sino que hay que aplicar protocolos muy precisos que tiene Hospital Seguro para ampliar la capacidad de respuesta en unos cuantos minutos. Y en su misma infraestructura, no quiere decir en el estacionamiento o en tiendas de campaña que no logran la eficiencia y la seguridad para los pacientes. En la siguiente diapositiva, que queremos recordar, next slide please, que el concepto de hospital seguro, sus principios, indican que hay que proteger la vida con construcciones antisísmicas, con todos los niveles de seguridad estructural, no estructural y de organización funcional, que la función se garantice en los momentos en que más se requiere, donde hay un mayor número de víctimas, y proteger la inversión, que todos los equipos que contiene el hospital, que son muy valiosos para otorgar la atención, estén en buenas condiciones. En la siguiente diapositiva, next slide, quiero compartirles algunas acciones estratégicas que tuvimos en mi institución aplicando el concepto de hospital seguro durante la pandemia. Quiero decirles que se hizo una reconversión hospitalaria, un aumento de la capacidad para recibir pacientes. Un primer paso fue la expansión interna de hospitales, convirtiéndolos en hospitales híbridos. Esto lo hicimos en 194 hospitales de mi institución. El segundo paso fue apertura anticipada de unidades que ya teníamos en proyecto para los siguientes meses, los siguientes años, se hizo una inversión adicional. Estos fueron 5 unidades que nos ayudaron mucho a poder resolver la demanda que ya existía. Luego, dentro de los hospitales se hizo también una en donde se detectó que íbamos a requerirlo, una extensión, un anexo al hospital en áreas muy bien diseñadas, con construcciones sólidas, con el concepto de hospital seguro y temporalidad, y estos fueron 18. Les muestro en la fotografía del lado derecho superior. Eso es el autódromo de la Ciudad de México, donde se corre la Fórmula 1. Se hizo una adaptación de una construcción ya existente de 4 pisos de altura, donde pudimos albergar 230 camas con su personal y los equipos. Esto demostró la versatilidad que se podría tener, obviamente aplicando los conceptos de hospital seguro. Y finalmente se tuvieron que construir 3 hospitales en algunas regiones del país donde se requerían. Esto implicó la contratación adicional de personal y la adquisición de equipo médico especializado. En esta diapositiva lo que les quiero mostrar es de que desde el 26 de marzo del 2020 ya teníamos disponibles en nuestros hospitales 1,252 camas para COVID, y para febrero 9 teníamos ya 19,982, todas con personal, con equipo y también el concepto de hospital seguro. En la siguiente diapositiva quiero, next slide please, quiero compartirles que también el equipamiento fue trascendente, es obvio para todos nosotros que estamos inmersos en la atención de esta pandemia, y aquí les muestro en 2, 3 etapas que siempre tuvimos una cama disponible, siempre tuvimos ventiladores y personal entrenado con los medicamentos correspondientes para los pacientes intubados. La oferta se mantuvo en este sentido, con la respuesta organizada y integrada de todo nuestro personal en la institución. En la siguiente diapositiva quiero compartirles, next slide please, el impacto que el programa de hospital seguro ha tenido en la respuesta a esta pandemia. Es muy sintetizado, pero es muy importante. Las áreas de expansión se tuvieron que hacer bajo un protocolo muy estricto, identificar las áreas de aislamiento en apego a estándares internacionales, y que nos está dando una gran experiencia para una publicación que compartiremos con todos. Y la seguridad no estructural, que fue determinante porque se instalaron líneas de oxígeno nuevas, área medicinal, se tenían que estar haciendo pruebas neumáticas para mantener los estándares deseables, que todos los pacientes tuvieran un flujo suficiente, y protocolos y procedimientos como rutas de evacuación en caso de que se integrara algún desastre adicional, como ocurrió, sistemas contra incendio, etcétera, todo concepto de hospital seguro aplicado incluso a las instalaciones no permanentes. En la siguiente diapositiva, quiero, next slide, mostrar cómo se hicieron, este es un video, no sé si se pueda proyectar, pero si no se los explico. Son áreas que rápidamente se instalaron en zonas ya diseñadas, en donde se complementó la respuesta dentro de los hospitales. Vemos ahí al fondo las líneas de oxígeno con todas las pruebas neumáticas que se requerían. La ampliación en la siguiente diapositiva, por favor. Next slide. Es la gestión integral de riesgos de COVID-19. Esta es la diapositiva. Nos vamos a esta por razón de tiempo. Y aquí quiero comentarles que la reducción de los riesgos de desastres dentro del índice de seguridad está en la gestión de riesgo. La continuidad en emergencias y desastres está en la gestión de la continuidad, preparación y respuesta multiamenaza. Esto es muy importante porque En nuestros países de América, no todos son huracanes y sismos. Tenemos, y ya está demostrado con la pandemia, los químicos, biológicos, radiológicos y nucleares, en donde nuestro centro colaborador junto con la OPS estamos trabajando ya protocolos específicos para esto. La vigilancia hospitalidad, pero sobre todo el nivel de seguridad, garantizando la permanencia de nuestros pacientes en este sentido y la del personal. En la siguiente diapositiva quiero mostrarles, next slide please, cómo se hizo una capacidad de expansión. Quiero decirles que esta experiencia que se ha tenido, no solo en nuestro país, sino en todos los del mundo, se está recopilando como centro colaborador junto con la Organización Panamericana de la Salud para publicar una guía para expansión de servicios protocolizada. Y todo esto va a estar alineado con el plan de reducción de riesgo de desastres del sector salud en línea con el marco de Sendai. En esta diapositiva les muestro en el lado inferior izquierdo, es un hospital muy importante del norte de nuestro país. Esa era una sala de espera en donde al fondo está la terapia intensiva, está todas las áreas críticas y es permanente. En las paredes está ya preparado todo el flujo de gases medicinales. En la siguiente diapositiva tenemos, next slide please, tenemos lo que hemos encontrado. Cuando se tenga que renovar una estructura, como se mencionó en Sendai, hay que reconstruir mejor. La capacidad de respuesta está ligada con la capacidad de expansión. El nuevo modelo de gestión integral de riesgos, en donde tenemos que tomar en cuenta QBRN, entre otras cosas. El protocolo es trabajar sobre la multiamenaza. Y next slide, please. Tenemos aquí que Hospital Seguro ya existe, ya lo tenemos, está sólido. Hay que agregar la parte de multiamenaza, hay que agregar la capacidad de expansión, todo esto con protocolos avalados por la OMS, OPS. Tiene que ser respetable con el medio ambiente, aplicando los objetivos de desarrollo sostenible. Y finalmente, el respeto a las personas con discapacidad. Todo este es el nuevo concepto de hospital seguro, resiliente e inclusivo. Y en la siguiente diapositiva, quisiera, next slide please, and last one. Tenemos aquí ya en la parte final, vemos ahí algunos evaluadores de hospital seguro revisando una de las instalaciones para garantizar el nivel alto de seguridad para pacientes, para personal, dentro de este reto tan grande que fue la pandemia. Muchas gracias por la oportunidad.
Thank you. Thank you very much, Dr. Vega, for sharing Mexico's good practices. We are a little lagging in time, but I just wanted to say that we have to mention that creating isolation areas is a key infection control measure, but has often been difficult to achieve in long-term care facilities during the pandemic due to the architectural differences with other health facilities. Thus, Mexico's innovative example of enabling expansion, both inside and outside, is an extremely helpful to note. So thank you once again. I just would like to let the speakers know that we are lagging in time. So please try best to be within the 8-minute time frame. So now I would like to invite Dr. Hong-Soo Kim, professor at the Graduate School of Public Health, Seoul National University, Republic of Korea. Dr. Kim, 8 minutes, and thank you very much once again for attending. You have the floor.
Okay, yeah, thank you very much for the invitation. It's an honor to have an opportunity to share South Korea's experience of the COVID-19 situation and our long-term care response. And next slide. Yeah, this is the content of my presentation. And next slide. South Korea has a very rapid aging population. Next slide. South Korea is a country in Northeast Asia with a population of 51 million. The number of older Koreans is about 8 million. As of March 14, there have been about 95,000 confirmed cases of COVID with about 1,600 deaths. So the COVID case fatality rate is 1.75%, which is relatively low compared to many other countries. We experienced 3 severe attacks, so first wave and second wave, third wave. The third wave is most severe one. Next, please. This is a graph shows the current status of COVID-19 in Korea. You see the COVID-19 impact by age group in Korea. So most confirmed case can be found in like a 50, between 50 and 59, but you see the death rate and fatality rate is severely increased in the older population. So the 80 plus group, the oldest old group, have the highest fatality rate. And next slide. And this slide shows a slightly different statistics. It shows among the deaths where they infected in COVID. So you see at the bottom of the slide, about 200 out of 1,600 COVID-19 deaths were patients presumed to have been infected in nursing home. That is about 13% of total deaths. Another 400 deaths were patients presumed to have been infected in long-term care hospitals. So that's related to both types of settings, about 37% of total deaths for COVID-19 in Korea so far. Next slide. And among the group, we see the number of people, quite high number, presumed to infected in Korea, but this is, I think, is a relatively minimal impact considering the number of people in the 2 long-term care settings in Korea. This is one of the recent statistics from OECD, and you see South Korea is one of the countries the most high increase of long-term care bed at the very left. So there are more than 5,000 nursing homes and 1,500 long-term care hospital beds in Korea. And the number of people institutionalized in both settings is more than 600,000 at the end of 2019. And next slide. But so far, we have no reported deaths in the long-term care facility, care homes. All residents confirmed positive were transferred to hospital upon infection. No deaths in long-term care facility have been reported as of this presentation. There was a sharp increase in the number of long-term care hospitals put under cohort isolation during the 3rd wave. So I guess there are some deaths in long-term care hospital, not transferred to acute hospital, but so far official reports on the number of deaths in that setting are currently unavailable, unfortunately. Next slide. So then what we've done to fight this COVID-19 in the community, the Korean key quarantine strategies are massive test, trace, and treatment. So for test, first we prevented the importation of the virus through border screening, but we didn't lock down. And second, the early detection and containment. We have 600 public health center and medical institution work agent screen stations, and various forms we did a screen, like a driving through, walk through, we did, and more than 200 testing facility, and maximum daily testing capacity is 200,000 people per day. And third, we have very massive contact tracing and monitoring measures we used. we have used not only epidemiologic survey, but also various objective data, such as security camera and footage. So there is some issue of privacy issues. So recently the use of those data more carefully used, but basically compare other countries, we use very strict massive contract strategy. And lastly, treatment strategy. So some moderate and severe cases were hospitalized immediately, and some mild cases are quarantined at home and leaving treatment center for 2 weeks. Under these strict community measures, next slide, I will present the long-term care facility related measures. Next slide, please. So for the long-term care institutions, the Central Disaster and Safety Containment Headquarters, CDSCH, has developed a wide range of preventive measures against infection in high-risk institutions, including nursing home and long-term care facility. So key measures include monitoring resident health, providing public masks, education on infection management, and instituting staffing level measures. The entry visitor to nursing home have been restricted, and stringent entry and exit management have been implemented for workers and residents. Next slide. Temporary court isolation for long-term care institution with the infected case has been implemented, and preventive tests for all long-term care residents and workers in special disaster zones are conducted regardless of the clinical symptoms. And there are additional measures to contain COVID-19 in these settings. The public long-term care insurance implemented temporary reimbursement plans, and we also provide long-term care service provider may order public masks at a low cost. Next slide. And yeah, these are some photos you can see about what we've done to fight COVID-19. And next slide. And recently, we also released a guideline and checklist for COVID-19 response in healthcare institutions, particularly for long-term care hospital and mental health institutions. The guideline you see next in Korean include a to-do list for preventions and protocols or confirmed cases. And this one is particularly based on WHO's protocol and checklist. And this checklist include at the bottom, bullet point, the task force team setup, staff education training, PPE, symptom surveillance, and preventive measures and visitor protocols. These include 13 items. Next slide. And you can see this is the reference we used for our guideline for our setting, but WHO provides very good guideline. Thank you so much. Next slide. This is an additional checklist and to-do list. What's the key to-do list we provide for long-term care hospital includes basically 6 domains. Set up a COVID-19 task force team and adhere to preventive protocol for patient classification, and staff education regulation is very important, and limit outside visitors, and training for care staff, and track movement within facility. We also provide more detailed staff checklist, includes about 30 items, and it includes 3 domains about facility and staff caregivers and last environment. Next slide. Yeah, this is the summary of the quite full detailed guidelines. So it includes 4 domains. It's I've already mentioned. So just for your reference.
Dr.
Yeah.
Kim, please really wrap up. Thank you.
Okay, yeah, this is just, yeah, family visiting without direct contact. Next slide. So what's the lesson learned? I think responding to COVID-19 is really health and long-term care system measures. So the response should be planned and executed across both systems while keeping community level measures tight. And second, still the individual long-term care institutions and their association has very, very important role and responsibility to fight COVID-19. So we need to strengthen their capacity for responding to ongoing and future pandemic. And it also has implications for future health and long-term care system reform in my country. And last, we need for better gender balanced COVID-19 response at all levels. And the unequal impact of men and women. Large number of women are front healthcare workers. They have a very important role and unique challenge. We need better gender equality in leadership. This is the end of my slide. Thank you so much.
Thank you very much, Dr. Kim. Excellent end to your presentation. Yes, many of the caregivers and carers of residents of long-term care facilities, but also home long-term care services are women and older women themselves. So we do need gender balance in terms of support for caregivers as well. But I think what's amazing is that South Korea has had no deaths within long-term care facilities, although a lot of the deaths were linked to the facilities itself. And I believe that it may have been due to the actions in Korea where there was a coordination between the national task force teams, so the central, the regional, and facility level, with strong guidance provided by the national level and a focal point within facilities to implement the guidelines provided at the national level. So thank you very much for your presentation and your contribution. I have so many things I want to discuss, but I realized that we're tight on time again, so I will move on to the next presentation. I would like to invite Dr. Joanne Reif-Snyder, Chief Nursing Officer of Genesis Healthcare USA. As we all know, Genesis Healthcare is one of the largest nursing home providers in the US. Dr. Reif-Snyder, you have 8 minutes and you have the floor. Thank you.
Thank you, Dr. Han. I'm grateful for the opportunity to be with you today and to share the experience of Genesis on the ground. Second slide, please. For context, there are approximately 15,500 nursing homes in the United States, and prior to the pandemic, roughly 1.4 million people lived and received care in them. The average size of what I would say are the more modern facilities is 100 to 120 beds, but most were built in the 1960s and 70s. Most rooms are semi-private, and some larger rooms accommodating 3 or 4 residents are still quite common. 70% of the care in nursing homes is funded by medical assistance or Medicaid, which is our country's medical insurance program for the disabled and poor. So Genesis operates about 325 facilities in half of the states, slightly less than half of the states in the US. We have a physician and nurse practitioner practice, rather large. These professionals are the medical directors in all of our sites and directly provide the medical care in about half. Next slide, please. At Genesis, we experienced our first outbreak almost exactly 1 year ago on March 16th in Burlington in the state of Vermont. The early epicenter in the US was the New York metropolitan area, and the contiguous states of New Jersey and Connecticut quickly became hotspots. From the start, we collaborated with our colleagues at Brown University, sharing all of our data so that together we could learn everything possible while the pandemic was unfolding. Next slide, please. Early in the pandemic, media reports were quick to fault nursing homes for outbreaks and case numbers. At the time, testing, of course, was unavailable. It was prioritized to hospitals. PPE was becoming scarce, and absent a way to identify asymptomatic and pre-symptomatic nursing home residents, it was really impossible to effectively cohort. And so case numbers did grow. In our work with Brown, we discovered that the nursing homes most affected were those located in counties with highest prevalence and those with more beds, larger facilities. And these factors relate, of course, to the numbers of people coming into a facility, the traffic in and out, as larger facilities have more staff, and the exposure in the community of the people who worked in the homes. And this fact was important politically, as many US politicians and other leaders have some antipathy toward the nursing home industry generally. Next slide, please. Having established the context, let me move on to the crisis response strategies that my colleagues and I put in place, all of which are still in place. Most important, of course, was infection prevention practice. We already had a dedicated registered nurse position in every site pre-pandemic, and those nurses are responsible for infection prevention and nursing education. And to supplement their presence, we created a position that we called an IP designee on every shift, on every unit, to assure that rounding, observation of practices, coaching, and correction were possible in the moment. And additionally, we used iPads to conduct virtual infection prevention rounds, during which a team of our experts outside of the facility could round from a distance while a staff member carried the iPad. This was one of the most effective ways of assuring that new guidance was implemented and to check in on and support staff morale. Next slide, please. New tools were quickly developed by our technology team, and what might have taken months or even years to develop previously was developed within weeks, including a surveillance tool that allowed every site to track cases, a cohorting tool that prompted and tracked movement of residents inside of the facilities to reduce transmission risk. That's what I'm showing on the screen. And because most rooms are semi-private, shared by 2 residents, we needed to put into service ancillary spaces in the facilities to allow for isolation of sick residents. And we also developed a calculator for PPE needs based on case counts, which we later shared with the Centers for Disease Control, and they made available to others. Next slide, please. There was no complete playbook for COVID-19 in nursing homes, so we developed guidance documents based on CDC and CMS direction where such was available, or based on our own data analysis and expert opinion where published evidence to direct our practice didn't exist. And we pushed all of this to the field on a daily basis. Next slide, please. There are hundreds of pages of guidance now in a searchable database to which all of our site leaders and staff have access. We operate in 24 states, as I said, and there was frequent variation in approaches and directives across the states, making adherence to a single set of practices much more difficult. Next slide, please. By early to midsummer, it was clear that staff were becoming exhausted by the demands of PPE use, and we saw some drift in practice. We reached out to behavioral economists at the University of Pennsylvania who engaged with us to study the challenges and help us to put additional supports in place. This slide depicts some elements of an identity campaign to increase engagement and fidelity to IP practices while at work, when commuting to work, and when at home. Next slide, please. In mid-December, the first vaccines were available in the US, and nursing home residents and staff were the first priority. We've now, across the country, vaccinated more than 80% of all nursing home residents, and Genesis data are similar to that. We've had less success, unfortunately, with nursing home staff. Nationally, across all nursing homes, we're only over 30%. At Genesis, we were able to get over 60% by engaging our medical team in Ask the Doc sessions and many other interventions that we put in place. This will be ongoing. Next slide, please. We had to make some changes in therapy, of course, on-unit therapy versus therapy in common areas to reduce transmission risk, as I've said here. Therapists needed to create smaller gyms on each unit with portable equipment that could be sanitized. And therapists and our medical teams alike use telepractice, telemedicine, of course, to bring needed services to residents. Next slide, please. Here's an example of rehab team guidelines that we've been using to support post-COVID recovery needs. Next slide. Finally, an interprofessional team of therapists, nurses, physicians, social workers began developing our recovery strategy last summer, although we knew that we were far from the end of the pandemic. And in this, we focus on emotional, social, and physical well-being and engage all staff in simple revitalization interventions to address the effects of isolation. Next slide, please. We've learned a great deal in the past year. The lessons, some of which you've heard from other speakers, are depicted here. And in my last slide, this depicts a report issued from the American Healthcare Association, which is the trade group that represents about 70% of the nation's nursing homes. Just yesterday, the Senate Finance Committee held a hearing on nursing homes, and the chief medical officer of AHCA talked about this report and testified about the toll the pandemic has taken on nursing homes. And he detailed this proposed Care for Our Seniors Act, which will address, we hope, some of the many issues that need to be addressed in this sector. Thank you.
Thank you, Dr. Rice-Snyder. I mean, this is an excellent overview. As we know, initially the U.S. certainly faces 40% of deaths were linked to long-term care facilities, including nursing homes. And in many countries, in some countries, not many, in some countries, there was national oversight, but in others, it was really the institutions themselves or the facilities themselves looking into practical ways to adapt to the pandemic situation. And I think Genesis Health has really was a game changer in the US in terms of strong referral systems and information channeling between long-term care facilities and hospitals, but also creating practical tools like the calculator of PPE, which the CDC was well received as well. So thank you once again for sharing your experience. I will now go for our last presentation, Mr. Hugh Masters. I would like to invite Mr. Hugh Masters, Associate Chief Nursing Office, Pandemic Response Chair of Perinatal and Infant Mental Health Program Board from Scotland. You have 8 minutes, please. Thank you.
Thank you, Dr. Hahn, and thanks for the invite. And just on that first slide, there are my colleagues who have worked around this pandemic for the last year, incredibly hard. So I just wanted to pay tribute to them as well. If we could go to the next slide, please. So what I wanted to talk about today and was asked to talk about was, I guess it follows a bit from Dr. Rice-Snyder's talk, which is the sort of learning, the moving on from the pandemic, the thinking about where do we go from here. And what we have here is guidance that we produced in February called Open with Care, supporting meaningful contact in care homes. And this is very simply about visiting. Now, it might seem a small thing given the huge presentations that we've seen, but actually in the life of long-term care facilities and what we're talking about here, older people's care homes, that connection with family is an enormous issue and one that has been very badly missed for the last year and one that we felt needed to be addressed. So we're couching it not as visiting, but as meaningful contact. So, and in terms of public anger, public outcry, letters, the media, this has been a huge issue for us in Scotland. So hopefully it will provide some help and guidance, but a little bit of background for you about Scotland. The next slide, please. So Scotland, which is part of the UK, not part of England, as some people often think it is, but we're moving through the pandemic. Our numbers are currently falling and have been falling, but you'll see that most of it is centred on that middle part of Scotland, which is heavily populated from there. And we have had just over 200,000 people have tested positive for COVID out of a population of just under 6 million. Next slide, please. So this is the situation for residents, and one of the previous slides showed that in Scotland, yes, our older people's care homes have been hit hard by COVID, with a lot of deaths and a lot of infection. We have 1,000 care homes with about 33,000 residents, and the deaths have been around about 3,500, accounting for, at the peak, over 50% of all deaths in Scotland, and at the moment about a third. And you'll see from here that we've had 2/3 waves, and we're currently, the numbers are dropping off dramatically over the last month. You'll see in the middle there that the numbers were much less in terms of those people who were COVID positive, but obviously visiting was stopped in that early period in March 2020, sort of began a little bit during the summer, but was stopped again over that period and has been that way for quite a long time. I should say that all care home residents are now vaccinated and have had their vaccine in Scotland, and Thankfully, we've had better success. So far, we've got over 80% of staff who are vaccinated too, and many of those who chose not to have it first time are now changing their minds and going for for the vaccine. So next slide, please. So this year we looked at really a hard look at what is the risk of COVID transmission, specifically from visitors. And we looked at the evidence base for that. And again, I think Dr. Reichschneider indicated some of the factors that we know are associated with transmission in care homes. But then we looked at what we're able to do now to protect care homes. We looked at the harms of social isolation, of loneliness, of lack of belonging, of lack of purpose. And looked at some of the excellent guidance, of course, that WHO provided beginning of this year about the need for contact and human contact. And through that, we developed this Open with Care guidance, which is now in operation. So next slide, please. And that revolves around 10 key things. Again, others have provided lists, and this is around our ability now. We're not March 2020, this is March 2021. We understand all the IPC, we have visitor testing in place, we have oversight in place, and importantly, but not exclusively, we have vaccinations in place. And I think we feel we would be having this approach whether we had the vaccination or not in place. So this is critical for care homes to be able to show this for visiting to happen. So next slide, please. And what we're moving towards now is indoor visiting, where visitors come in a couple of times a week, and that increasing as care homes feel more confident to allow more people to come into the care home and to have visits out. We are not looking at window visits or outdoor visits or anything like that. We are focused on that meaningful contact indoors, and to have touch as well, and to have brief hugs. So that people have that family contact again. So next slide, please. But also making sure that if essential visits happen, so when people are distressed, end of life, those are able to be accommodated. And all of our guidance now is like this. It's easy to follow, we hope, and shows the importance of that. Next slide, please. We've also clarified what is needed for personal protective equipment when visitors are in the care home. It had begun to have lost its evidence base with the use of gloves and aprons and all sorts. And we've gone very much back to saying it's about masks and it's about hand hygiene. And we've produced documentation that we hope is clear about what is needed and what the evidence base is to prevent transmission. So next slide, please. And again, we're not doing this in isolation. We've worked really hard with relatives groups, with all of our partner agencies who do the scrutiny and inspections and the oversight of it to make sure that visiting or meaningful contact is seen as something that is absolutely crucial to happen. It shouldn't just be seen as a luxury item. This is something that's central to care and a fundamental of care. So it's not just about the document. So your next slide, please. So what have we seen since we published? Well, the orange line that goes up and down there is the number of outbreaks that there have been in care homes over the past 6 months. And you'll see that thankfully that is receding fast. The blue line shows where indoor visiting was happening. And you can see that since February, we've had a pretty enthusiastic response from care homes. We have now over 80% actually who are doing indoor visiting. We're about 3 or 4 weeks since we implemented this. We're not seeing any increase in outbreaks at the moment. Lots of nervousness, lots of anxiety from staff and residents and relatives about this, but everybody understanding that it's something that as we move through this after a year, it's so important that it happens. So last slide, please. So just to show that this is the sort of meaningful contact that we're talking about here, that is happening, and just how important that is for it to happen. We're also working hard with visitors to make them understand that they have to play the part in this. They can't take their masks off, etc., etc. But so far it's been enthusiastically embraced, and we hope that we can move that debate along from either closing from visiting or just seeing family members as visitors rather than a central part of relatives and residents' lives. Thank you very much.
Thank you very much, Mr. Masters. I think actually a very moving presentation as well. It touches on the emotional that we have not been able to as much as we should have during the pandemic. We have from the beginning of the pandemic, when long-term care facilities became epicenters of outbreaks, I think concerned voices were voiced not just in Scotland, but globally, really asking for a balance between IPC and human contact. For, as we know, people with advanced dementia, recognition of loved ones isn't successful through screens or monitors. That touch and meetings in real life is what really gets them going and allows them to recognize the presence of their family. And so the issues around visitation were not have been an ongoing discussion and very important and really central to long-term care facility agenda and IPC. Therefore, in a recent IPC, WHO's IPC guidance for long-term care issued in January, WHO has tried to balance IPC measures and visitations and really emphasizing that maintaining human touch and contact is an important and integral part of long-term care services. So thank you very much, Mr. Masters, for sharing the Open with Care today, which is a compassionate and innovative approach to maintaining successful visitation and human presence for residents of long-term care facilities. So thank you very much. Well, ladies and gentlemen, that concludes our 5 excellent presentations for this third webinar. I am now opening the floor for Q&A. So we do have some meaningful questions, and I have, let me just check once again. I have a few questions, and one is I think it would be best to direct to Dr. Hanadi. Dr. Hanadi, are you there? Great, thank you. So as we know that there were staff shortages in hospitals, but very much so in long-term care facilities. And so one question is, do you have enough staffing? Because you mentioned that you were also looking into IPC, looking into acute care monitoring, but also you used telephone and other modalities to monitor and manage care at home. So do you have enough staffing? How did you manage to compensate for the staff surge that was necessary to manage the COVID-19 situation?
Excellent question. Part of national strategy to face the pandemic, recruit workforce. So we have many workforce in Qatar, but they are not under our facility. So we recruit them temporary for a period of 6 months after we did the basement and the basic licensing needed, and it was fast track. In addition, some of the private sector, they close their outpatient services. So deploying, and we work as a team to enable and manage and cover the department needed support. Thank you.
Thank you very much. Because we're already past 2 minutes, I think we would have to wrap up, but don't worry with the questions because we will be able to provide additional answers to the questions that you have asked. The COVID pandemic has highlighted challenges for long-term care, as Dr. Kelly mentioned in his opening statement. However, we have seen that with concerted action, we can prevent, mitigate, and manage the situation we see in long-term care facilities. With the outbreaks, countries have worked strenuously in terms of surveillance, in terms of adapting and on ground as well. So hopefully today's experience sharing will help to further strengthen our efforts and create safe hospital and health facilities, including long-term care facilities globally. We have successfully concluded the 3rd session in the COVID-19 Safe Hospital webinar series. Thank you very much once again to each and every panel speakers, opening remarks speakers, and all participants from the world for your active participation, as well as deeply to the organizers. See you in the last and 4th webinar of the series, scheduled next month on the 15th of April, 2021, and look forward to a successful webinar. Again, thank you very much.
Thank you.